A very good afternoon to all of you. Uh, it is 3:01 now. Request if all of us can wait for about 2 more minutes. And then I'm just trying to get in touch with our director. With her introductory remarks, we could kickstart today's session. Kindly be online. We will start in another 2 to 3 minutes time. Thank you.
Girish, do you want me to start?
Yes, madam.
Okay.
Very good afternoon to all. A warm welcome once again to the second edition of the Mental Health Dialogues. I have the privilege of requesting Professor Pratima Murthy, our director, who has been a source of our support and a constant guidance and inspiration. Madam, this is a very important topic with respect to mental health and related issues. Request you to give your thoughts on this.
Thank you very much, and good afternoon to those of you who are in India, but I understand there are people from so many different countries, and therefore a good day to everyone. This is the second in the series of the mental health dialogues, and it becomes very critical because I think we're now moving from looking at individual concerns in terms of mental health to looking at public mental health. So there has been a huge amount of interest in looking at how we can reach mental health care to the populations. And when we do that, one of the concerns that all of us have is in the area of the growing concerns about suicides. We know that this has been on the increase, especially we are concerned about what's happening in our country. We know that some of the demographics of suicide in India is quite different as compared to the rest of the world. But the biggest concern is perhaps that amongst people between the ages of 15 and 30, death by suicide becomes a very major cause of death. And that really makes the whole topic so much more important. We also recognize that suicidal attempts and completed suicides among children is something of a growing concern, as well as the elderly population. So looking at it from a life course approach, there are different risks that we need to look at. And when we want to mitigate these risks, there are, of course, there's a need for a deeper understanding of what precipitates either a completed suicide or attempts at suicide. And we know that this is fairly complex, but at the same time, we need to look at what are the underlying risk factors and the determinants. What are the individual factors? What are the family factors, the social factors, and societal factors? More importantly, also, the issue of stigma and help seeking. One of the, we've addressed this, especially particularly during the COVID, through the launch of the NIMHANS, which is a telephonic helpline, which several people have reached out to. One of the concerns that people call in addition, of course, to issues like feeling sad, not being able to sleep, anxiety, is also, the ideas that life is not worth living, helplessness and hopelessness. And some of the experiences gained from this suggest that there is a huge potential for prevention. In fact, I would not hesitate to say that perhaps every death is preventable and every death by suicide ought to be prevented. So in that connection, I think it's important to get a much deeper understanding of the topic, from epidemiology to underlying risk factors, protective factors in society, against suicide, media reporting, how do you reduce access to means of trying to end one's life. So there are so many issues, right up to policy. And therefore, I'm sure this program is going to be very, very useful for those who are attending. I'm so glad to see almost more than 150 persons who have logged into this program. And I'm sure thinking about this, introspecting after we've heard the speakers and the discussants who have a rich amount of experience in the area, all of us will start thinking of what is it that we can do towards prevention. And of course, helping people who are in this situation where they feel that there is no option but to take their life. So this is going to be very, very important for all of us. I congratulate the team for actually taking this up, and I hope we have a very fruitful discussion. Thank you very much. Back to you, Girish.
Thank you very much, madam. As you rightly said, first we will look at the larger challenges in suicide prevention, including looking at the burden and what we need to do and what is going on in the country. Then Dr. Senthil Reddy would be talking about us. Then Dr. Senthil Amudan would be taking us through the National Mental Health Survey results about the suicidality, risk of suicidality. Then Dr. Anish Cherian will share with us the community-based models for mitigating suicides in the country. We seek your permission, and then we will continue with the next session, madam. Thank you. Thank you, madam. Madam, you're muted, but thank you. Okay. Thank you. With those words, I see a lot more people whom I could recognize, but warm welcome to one and all once again. Before I hand over to our team, I take this opportunity to wish Dr. Prabha Chandra warm greetings on her birthday. Madam, warm wishes. She would be chairing the first session. Over to our team, Dr. Sonali, Dr. Navya, and all.
Thank you, sir. Good afternoon, everyone. Am I audible?
Yes, please go ahead.
Okay, a very warm welcome to Mental Health Dialogue on Suicide Prevention. Before we begin, I will quickly introduce myself. I am Dr. Sonali, Project Coordinator for the NMHS 2, and I and Dr. Navya will be the moderator for today's discussion. It is my pleasure to welcome our speakers and discussants to this webinar. Their insights and expertise will be invaluable to our discussion today. Suicide is a serious public health issue, and it is important to raise awareness and promote suicide prevention. So now, without any further delay, let's welcome our first speaker, Dr. Senthil Reddy, sir, who is Professor of Psychiatry in NIMHANS, and he will be talking about the prevention of suicide and will give us an overview of the challenges in an Indian context. This session will be chaired by Dr. Prabha Chandra, ma'am, who is Professor of Psychiatry in NIMHANS. Wish you a very happy birthday, ma'am. So let's start our first dialogue. Over to you, sir and ma'am.
Thank you very much, Girish and team. Am I audible? Yes, just give me a thumbs up.
Yeah. Yes, madam, you're audible.
So it's wonderful that we are discussing suicide prevention in this month, which is a suicide prevention month and a very important month for all of us, from September 10th to October 10th. And what Dr. Senthil Reddy is going to talk about today is again important for us going forward, because the challenges in the Indian context, as you will hear from what he says, is not necessarily the same challenges that the world faces in terms of suicide. There are some commonalities, but there are some unique differences in India. You heard some of them, the director mentioning it, but young people dying due to suicide is very high. And also we have huge challenges about regulation related to media reporting, and that is a problem. The other unique issue that is there in India, again, which Dr. Senthil will talk about, is the causes for suicide. Some quite varied and different. And there is also the whole area of women and suicide, which is again quite unique to India, that the rates of suicide are much higher than the rest of the world among women. We are probably the country which has the maximum number of women dying due to suicide. And these are all interplay of not just psychiatric problems or depression, but a whole range of social problems. So I'm not going to come between you and the speaker. Dr. Senthil will speak for about 20 minutes, and we will have 15 minutes, and we will have about 5 to 8 minutes for Q&A. So please put your Q&A on the chat, and we will try to address some of these. Dr. Senthil Reddy, to introduce him, he's my young colleague, a very well-known researcher and clinician in the area of suicide, has trained people in the Army, in the Air Force, Border Security Force, universities, and is a passionate advocate for suicide prevention. So I'm going to hand over to Senthil.
Thank you very much, ma'am, for that very warm introduction, and I'm really glad that, in a way, a lot of my discussion today, and what I wish to share with all the attendees today in this particularly very relevant session that, as Dr. Prabha has already highlighted, is given that it's the National Suicide Prevention Month in a way, rather than just a day that we observe National Suicide Prevention Day. So, what I'll do without further, discussing aspects, I think I'll jump straight into my this presentation, and please, at the end of it, we'll probably have hopefully a more constructive discussion. Please do let me know if my screen is visible to everyone.
It is visible. Thank you.
Thank you. Yeah, so I'll just get straight into it. So just to give you a quick outline of my talk, we're just going to be covering certain things that our director has touched upon, as well as Dr. Prabha has, probably looking at it from the context of the Indian setting, how the constructs of suicidality, it stands as it is most recently with the emerging research, and what are the models that have evolved, and what are the sort of strategies that have developed, or what are the sort of broad constructs that have been advocated primarily by the WHO and that have been adapted to various countries, and what exists in India, and what are the sort of gaps that are there, and how we can probably attend to these gaps to ensure that we can address this very big challenge that we have, suicide in our particular setting. So this is just to give you a quick brief and overview of the nature of suicide rates across the world. If you notice that the global rate is pegged at 9 individuals per lakh population, but as you can see that the India, which is in bright orange, the rates are exceeding 9, and they stand at anywhere between 10 to 15 per lakh population, which is in the higher end of the spectrum. And this is as per the WHO. Now, if you were to look at, there were two very important things that I wish to highlight as well. This is about the lower middle income countries, which are highlighted in yellow, and the age bandwidth in which these deaths due to suicide occur vis-a-vis the higher income countries. And as you can very clearly see, there's a disproportionate overrepresentation from the lower and middle income countries, and a large proportion of suicides, close to 80%, are contributed from the lower middle income countries across all age groups. If you look at what just Dr. Prabhat had touched upon, as the age of 18 to 15 to 29 across the world, it's actually amongst the fourth, within the 4 leading causes of death in this particular age group. Although it is the 4th for overall between the genders, but when you look at it between genders, it's actually number 3 amongst women and stays at number 4 amongst men. There is a particular reason why I wish to highlight this, because I bring it back to how it relates to the Indian context and the contrast and challenges. So just getting back into what are the barriers broadly in the Indian context. There's the limited understanding of the scope of the problem within the Indian state. So I'm talking about what are the geographical, regional, and social cultural aspects, given that India is a very diverse society and culture, and a lot of aspects that may pertain to a certain part of the country, like the western part, may not be necessarily applicable to the southern part vis-a-vis the northern part or the central part. There's a major gap in research, and this is a lot of it is worldwide, and importantly, whatever research does exist worldwide is not necessarily relevant to the Indian context because of the disparities and the differences in various domains, both socio-demographic and clinical aspects, as have been touched upon as well. The other concern that is there is whatever limited data we have, its reliability is quite suspect, because it is just generally comes from the National Crime Record Bureau data, and so we don't have any other source wherein which we can actually rely on accurate numbers in terms of mortality due to suicide that may be present in our country. And so it's estimated that whatever numbers are reported by the National Crime Record Bureau data, the deaths far exceed that, probably 2-fold or 3-fold, if not more. And the lack of skilled human resources, and both human and infrastructure resources, in addressing the challenge of mental health, but not necessarily just mental health, but importantly suicide, because it's beyond the scope of mental health. It's a public health issue, as Dr. Girish pointed out. And there is a high issue, high major barriers of, which are faced by the context of stigma, partly driven by the perceptions about what the legal implications of suicide are in the context of, in context, and the fact that it's a crime, or even attempted suicide, is a crime. And so there is a general culture and perception that people are very reluctant to seek help, fearing that they may be, fall under the purview of the law, and how those impact, their own near ones and themselves. The other aspect is the fact of limited awareness in the community, and the fact that, suicide is preventable. So there are a lot of myths and fallacies that exist in the Indian context, and often they reinforce and perpetuate the challenge that suicide poses, suicide poses to in the Indian context. And obviously the stakeholders, there isn't a really representation of all the individuals or stakeholders that would be particularly relevant or pertinent in formulating strategies that would capture, the majority of people, and ensure that the individuals at risk can be protected in a manner that will ensure their safety and well-being. And obviously the landscape that evolves very rapidly. Economically, as we can see, the country is growing very rapidly. There's a lot of, not just with the growth, what comes along is a lot of expectation. With the expectations also comes a lot of a subjective sense of disparity and disgruntlement. Apart from the fact of the penetration of the digital or the technology space, into the country, and how that gives everybody in the country a view of what the world stands like, what other parts of the world look like, and what their own expectations are, and how they can, go up in the same context. So again, just to give you the discrepancies between the world and the Indian setting, if you again look, India is actually, India remains actually, is, highlighted in orange, has a rate of 10 to 15, and this is particularly only for males, this map. And you can see the maroon color, which is across the US, majority of Africa, Europe, and Australia is pretty much, above 15, the death, the number of deaths per lakh population. If you look at now, conversely, women, there's very, very few countries where the rates exceed 10, right? And India is amongst as you can see very well, seems to be the only large country in the world that seems to have almost a similar rate as the men. Importantly, it's got an extremely disproportionate high representation of women who contribute, to the overall deaths due to suicide in the world. And this is one of the aspects that Dr. Prabha had highlighted, as to how not just necessarily it's about the universal, perceptions about the fact that males are at greater risk. Clearly, in the Indian context, it's pretty much both genders that stand at a very similar risk. If you look at the male to female ratios, again, like I said, everywhere else it's around 3 is to 3:1 or 4:1, demarcated by the maroon color or the dark orange color. But as you can see, the pale yellow color, which actually looks at between 1:2 or 1:1.5, that's the rate in the Indian context. That means, again, the risk is pretty much equivalent to, at best, 50% more amongst men. And when we come down to within India, this particular map, shows actually the rates where the green and the yellow are wherein the states wherein the rates are particularly high and exceed 10, 10 to 20 and more than 20 per lakh population. So as you can see, a large proportion of our country is having a huge burden of suicide, and the rates of suicide clearly per lakh population are quite varied and discrepant across this. Now, what is also very particularly striking from this map is the fact that if you look at the socio-economic determinants of these particular regions, you would notice that particularly like the southern part of the country, which is the socio-economic indices of development, are particularly high in terms of maternal mortality, income, etc. These are very, much more better than the rest of the country. But these states seem to have the highest rates of suicide, and that's what is concerning. It does not seem to align to the general dictum that poorer socioeconomic status issues, but and drive a greater risk to suicide. And this is, particularly from a GBD study that was done in 2016. So although India represents 18% of the population and 42% of that population is aged between this age group of 15 to 39, we as a country contribute to 1 in 3 deaths among women and 1 in 4. That's 33% and 25% with the ratio, like I said. And obviously it's the leading cause of death, and that is what is very, very concerning among the 15 to 39-year-olds. It's exceeding maternal mortality among women and road traffic accidents among men. And this is in reference to the earlier slide that I have shown with respect to what are the statistics with respect to suicide and where it falls and as a cause of deaths amongst this age group. Like I had highlighted, it doesn't correlate with socio-demographic index levels. Again, the causes as per the National Crime Records Bureau, the latest one, which was released in 2022. The causes are very diverse and varied, but if you look at it between drug and alcohol abuse and illness, there's approximately 25% deaths that are attributable, to suicide, and family problems constitute around 33%. The 3 family problems, illnesses, and drug alcohol pretty much reaches around 60% or so, close to 60%. And if you look at all the other factors, they seem to relate to pretty much of a certain type of loss at an individual level that seems to occur. And that's one of the major issues. This is not consistent with what studies have demonstrated from different parts of the world, where more than 90% of suicide have been attributable to mental illness. But recent research has clearly indicated that what is being sort of noted in India is probably the norm rather than the exception, and that research was probably premature and probably restricted to those regions where research was undertaken. And this model of suicide probably reflects that, and also forms the base for a lot of things that I'm going to discuss further about what are the social determinants and the individual risk factors. So if you look at quickly, it's a very congested slide, so I'm not going to get too much into the nitty-gritty of it. But if you look at it, there are social demographic factors, gender, which really doesn't apply in our context, but nonetheless, sexual orientation, issues of cultural heritage, education, employment. These are individual aspects that I'm talking about. Obviously, the stressful life events, as we've noted in the NCRB data, the exposure to suicides in various ways, exposure to trauma in various ways, aspects of mental illness, alcohol dependence, self-harm and chronic physical illness, and traits that evolve as a consequence of biological vulnerabilities, and how they interact with the social determinants, macroeconomic policies, public policy that pertain to consumption of alcohol, for example, social policies about, employment, housing, what in legislative and regulatory frameworks that influence various aspects of, public matters that, influence their life, cultural and societal values that stem from, many, many years ago to what is rapidly changing in the context of the Indian setting, and how that's evolving, like I said. And obviously, importantly, healthcare coverage and health system, capacity and responsiveness to this challenge of suicide, and the social fabric, and whether that stays, is intact and provides that protective component as to what was highlighted as well. So this is just another alternate model. I'm just trying to highlight how complex the models and understanding of suicide have become with increasing research. And it's clearly acknowledged that the model that probably, is that India faces is probably more likely the standard model rather than the exception. Now, stigma and how it influences suicide is something that's very, very important. And that's because it's one of the key aspects of suicide prevention. And there are stereotypes, prejudice, discrimination, which is at a public level, and at a personal level. What happens is that it impacts personal experience and self-stigma, particularly amongst those individuals, in different phases of suicidality. There's also the overlay of how mental illness stigma or the stigma, and whether there's an overlap in sense that people with mental illness have a stigma, and that drives and influences their perceptions of stigma and consequent suicidality. vis-a-vis suicide being interpreted or suicidality being interpreted as a sign of mental illness, which it is definitely not. And that's what the evidence is clearly showing. So what are the models that have been proposed? So this is a very large,
Dr.
broad
Senthil,
model.
you have 5 minutes.
Sure, ma'am. Thank you. So this is quickly to give you an overall approach about what drives the social determinants and how universal and selective interventions influence that vis-a-vis the individual risk factors, and how that involves the whole population and the individuals. And these are at the levels of strategies, community-based, vulnerable, and suicide-attempted. So the whole idea of the principle of the WHO was to use a live life model, which is proposed by the WHO as the strategy to adopt, and with the intervention using means restriction, interaction with enhanced media inputs and involvement, and informing the young and early identification. Interestingly, new suicide prevention strategies are present in 49 countries as standalone strategies, India being now. And this is started soon after the WHO came in, and the list is there and available through the WHO Mind Bank. All of you can access that, and we are listed specifically as a resource. The typical components obviously have multiple layers, and rather than looking at a pyramid or a top-down, bottom-up, I'd like to highlight the fact that policy is what drives the whole thing, and that forms the roots of the tree that can actually provide a canopy of protection to everyone in the society. The orange colors highlight what are done at tertiary or secondary level interventions or indicated intervention, and that is very, very important in the Indian setting. My colleagues, Dr. Senthil Amudan and Dr. Anish, will be talking a lot about primary prevention and the aspects. So just to give you a touch upon the resource deficits and the gaps, we are way, way short of what the mental health capacity would need to be, and the lack of restricted access to mental health experts, particularly when there is an incident of suicide. So I'm talking about when, again, we're talking about indicated intervention and, selective interventions. So this is an area that's a particular concern, and there's a broader scope in the Indian context that we need to look at. How it's being developed, the suicide prevention in India, which is evolved and which proposed, has come through a set of steps over the last decade, and that's included, and I'll just quickly get into it. Importantly, the National Mental Health Policy highlighted that there needs to be a reduction in suicides, access to care, mental health care, increasing human resources, and reducing stigma with increased financial. The Mental Health Act decriminalized suicide, and that was a core of the crux of aspects pertaining beyond mental health issues and its relevance to suicide. And obviously, the Ayushman Bharat, initiative was something that triggered off more into integrating into overall health and well-being construct as a UN sustainable goals. So there's been a huge, increase in human resource and capacity building in the preceding 4 to 5 years. That's led to a large coverage in the Indian context that has allowed for the, selective interventions and indicated interventions to be in place. These are also supported now with training initiatives now at the front line that have been activated. And obviously what was alluded to again from the COVID onwards, the Telemanas program. This has been wonderful, and this has led to the National Suicide Prevention Strategy being, having a solid foundation. And obviously the ecosystem permitted the entire construct of the, suicide prevention strategy to be, evolved and put in place. And there were several various aspects to this that permitted it, including what I just mentioned about the NIMHANS and the National Mental Health Act, etc. So the core objectives of the suicide prevention strategy in India are to establish the surveillance mechanisms within 3 years, so there are clear-cut timelines to make sure that suicide prevention services are available in MHP and across districts for in the next 5 years. We're sort of scaling up and reaching there, and then to integrate mental health and well-being curriculum and educational institutions within the 8 years. So there are short, immediate, medium, and long-term objectives that have been clearly stated. And obviously the priority areas look at focusing on media sensitization, looking at reducing means and restricting access to means, and strengthening the surveillance mechanisms in the country. And what is very important is we've adopted a multi-sectoral approach. So it's not just the government or a particular ministry of the government, but actually across various ministries because of the various multitude of causes that result in suicide, and looking at it from not just the government, but also involving all other key stakeholders from local health services, educational institutions, private sector, corporates, professional bodies, NGOs, and that permits a complete model. And I said, rather than the original model, this is the model that's currently being strongly advocated, is given the breadth and the magnitude of the issue that cuts across and beyond just mental health, it is very, very important that all various trees and the core of it is formulated, which in a sense, the principle of the National Suicide Prevention Strategy of India holds. And that is why it's probably likely to be more effective if this principle is implemented in its true spirit. So again, it's just leadership via excellence, creating capacity building through the centers of excellence, collaboration between the governments, as well as transsectoral input. One of the examples I'll just quickly touch upon is a gatekeeper training program that Dr. Prabha talked about. We train more than 10,000 people across a variety of different backgrounds. It's been excellent. There's no mental health. A certain proportion, a large proportion of people don't belong to the health sector at all. And what we've done is created a resource pool of people who can identify individuals at risk and timely refer them to relevant. So what's the way forward? Looking at acceptable strategies that are relevant to this context, creating a registry and repository, and universal surveillance system, and obviously using technology, which is already being done, and advancing the research so that we can modify strategies in the future. My last slide is just to touch upon the resource that is available with the WHO. It looks at various national suicide prevention strategies that are already in place across the world, and what is the progress with these, what are the examples, and what are the indicators, the success stories, the failures, the limitations, and how we could probably utilize and learn from these experiences that various countries have had from different parts of the world, and ensure that we can actually modify and adapt and adjust as the needs evolve over time. Thank you so much.
Thank you, Dr. Senthil sir, for this informative and thought-provoking presentation on suicide prevention. Now, I would like to request Dr. Prabha ma'am to give reflection on this.
Thank you, Dr. Senthil. I think you, obviously, I'm not going to repeat what you said because there are a lot of complex areas and challenges that you have highlighted. Most important among them being how social reasons seem to be quite important. And that is why any national suicide prevention strategy, I really like the way you talked about the roots of the tree. So it's not like a pyramid, which was the conventional model of suicide prevention. Universal prevention, specific interventions, and then going down to more deeper, but talking about how at every touch point, be it medical setup, school, colleges, police, there is opportunity for suicide prevention at every possible level and in every possible stage. But a very strong policy initiative and leadership initiative is extremely important. You also touched upon something very important, which I think people will talk about later in their Q&A, and that is about the relevance of social cohesion. There was a wonderful slide where you focused on how there's social isolation, loneliness, and a lack of social cohesion seems to be one of the important reasons, even in a country like India, to be the reason why people don't think that they can access somebody for help. People don't feel comfortable enough to access support. So I think that's something that possibly will be raised in the Q&A. There is going to be more discussion around suicide prevention. So I'm going to now close here, and we will take the Q&A at the end, Dr. Senthil, because all the three presentations kind of dovetail into each other. So thank you very much for an excellent presentation, and I hand it over to the organizers.
Thank you, ma'am, for sharing your thoughts. Let's move on to the next session on epidemiology of suicides. I would like to welcome Dr. Senthil Amudan sir, who is additional professor of epidemiology, to dwell deeper into this topic. And also I would like to welcome the chairperson for this session, Dr. Gauri Sengupta ma'am, who is DDG and director at Central Health Education Bureau. Over to you, ma'am and sir.
Yeah, thank you so much. I think first we're going to have presentations. So I would request Dr. Senthil to go ahead and give us our presentation, and maybe we can have the comments later. Over to you, Dr. Senthil.
You're muted.
Yeah. Thank you, ma'am. My slides are visible, sir.
Yeah, please go ahead. You can see.
A very good afternoon to all. I sincerely thank the team for providing this opportunity. For today's topic, I'll be focusing my attention on a recent paper in Lancet Psychiatry, where we delve into the epidemiology of suicidality and its correlates in India. This is a very crucial and often underreported component within the complex phenomenon of suicidality. It's my privilege to present one of the important contribution of global relevance from a large and unique exercise that involved efforts and hard works from 120 field data collectors, 297 experts covering 720 clusters across the country. To date, no single country has such huge data from the community collected from over 35,000 individuals using a systematic approach. Now, suicide is one of the leading causes of death in people aged 15 to 29 years. An estimated 75.5% of all global suicides occurs in low-income and middle-income countries. Reducing suicide is the only indicator representing mental health in Sustainable Development Goal 3. Thus, efforts to reduce and prevent suicides we will need data for both suicide and suicidality from a nationally representative populations. In fact, WHO recommends identifying and understanding suicidality as a key component for comprehensive suicide prevention strategies. It is very important to know that suicide and suicidality are two different ends of the spectrum. Suicide is the act of deliberately ending one's life, whereas suicidality refers to all thoughts, plans, and acts of suicide without a fatal outcome. Even though suicidality excludes mortality, the morbidity associated with suicidality cannot be overlooked. As individuals experience or live with disability, there is a great opportunity for everyone to extend a helping hand for such individuals, signifying the theme that creating hope through action. Now, there is an added advantage to study suicidality because suicidality itself is a social phenomenon with better prediction for suicide, where early interventions can be delivered to help prevent suicidality and death by suicides. Now, coming to our country, India accounts for 18% of global populations, but contribute to 26.6% of global suicide deaths. Though we have national information on suicide mortality from National Crimes Record Bureau and Global Burden of Disease Study, such information on suicidality is relatively absent in India. With this, we aim to investigate the prevalence and socio-demographic differentials of suicidality using data from National Mental Health Survey 2015 and 16. We believe that by providing a comprehensive, reliable information on suicidality for the first time from the large community sample, we believe that the findings will complement the available data to inform policies and programs towards suicide preventions in India. Briefly, National Mental Health Survey Phase 1 is a large-scale multi-site population-based survey from 12 representative states that used a multi-stage stratified cluster sampling technique for data collection. The data were collected using handheld devices by trained data collectors. A minimum of 3 follow-up visits were used to reduce the dropouts. This is the picture from various sites that were involved in National Mental Health Survey. This slide shows the robust data collection framework that we have used for National Mental Health Survey Phase 1. Now, coming to the suicidality assessment in National Mental Health Survey, the suicidality was assessed using suicidality module of MINI, which has 14 yes or no interviewer administered questions that focused on suicidality phenomenon that ranged from passive suicidal ideation to suicide attempt. Each of the items were given a differential scores. The scores were finally summarized, and the suicidality was finally categorized as low, moderate, or high. Given the difficult challenges that we face in collecting the sensitive information on suicidality, we also have adapted a robust adherence framework mechanisms to get a more positive response rate. Now, coming to the analysis, we have estimated the prevalence of suicidality overall, its subcategories, and also its phenomenon using a normalized sampling weights. As National Mental Health Survey does not collect information on death by suicides, we also have used information from the suicidal deaths or death by suicides from Global Burden of Disease study. From here on, suicides will be referred to as death by suicides. Now, we also have used regression analysis to examine the association between socio-demographic factors and overall suicidality. All the analyses were design based to account for clustering, the sampling weights, and also the multi-stage sampling of the complex survey data. Now, coming to the results, the study have estimated that the overall suicidality prevalence was 5.1%, indicating that 5.1% of the participants had suicidality in any form during the preceding 1 month. The most prevalent suicidality phenomenon was suicidal ideations, which with a prevalence of 3.5%. Further, it was also found that around 1% of the participants had high suicidality, and with 0.3% reporting attempted suicide in the past 1 month, requiring urgent interventions. Now, taking up the general differentials, we can see from the figure that the overall suicidality was higher in women than in men for all the age groups. Now, when we extend further to look at all the levels of suicidality, even at all the levels of suicidality, the prevalence of suicidality was very high in women than in men for most of the age groups. Now, when we take only the overall suicidality, the prevalence of overall suicidality was very high in 40 to 49-year age group, was highest. The peak in 40 to 49 age group among women, whereas in case of men, the peak was observed at over 60 years and above. This indicates the challenges that we will be facing in delivering the programs for recognitions and care for elderly. Now, coming to the differentials across areas of residence, among the participants from the different areas of residence, higher prevalence of suicidality was reported from urban metropolitan regions, followed by rural regions for any levels of suicidality. The same trend was also observed among men and women. When we take high suicidality, it was found that the prevalence of high suicidality in urban metropolitan region was twice the times that of rural regions and twice the times that was reported from urban metropolitan regions, highlighting the urban needs with regard to suicide preventions. Now, when we analyze the prevalence across the various states, the prevalence of suicidality, suicide attempts, and suicide deaths were actually varied substantially across the states. That indicates that we actually have missed out these variations when we look only at the estimates from the national level. The study also have found that for every death by suicides, there were around 210 suicidality and around 15 suicide attempts for the country. This ratio also have differed significantly across the states with distinct gender variations. Now, this figure is the most important contributions from the National Mental Health Survey data. When we look at this figure, it can be shown that the distribution of suicidality prevalence across the surveyed states, as shown in figure A, is quite distinct and substantially different from the distribution of death by suicides for the same corresponding states, as shown in figure B. This clearly indicates the heterogeneity of factors that operates at the state level that can affect and lead from suicidality to death by suicides. These attributions can be related. These differences and differentials can be attributed to differences in the educational attainment between men and women, geographical heterogeneity in terms of culture, caste, and the religious compositions, the modernizations, urban-rural compositions, the agricultural employment, socioeconomic development, access to means, the health systems, and the civil registration systems that varies across the state. In fact, this is the most important finding that the study has emphasized, that the implementation at the state level and community level actions should be derived from the state level factors based on state level data. Now, looking at the regression analysis, analysis also have highlighted the importance of socioeconomic factors in suicide preventions. Our nuanced in-depth analysis have led to 23 different tables on suicidality, examining the socio-demographic factors. For the sake of time, I'll be focusing on two important tables. The first table is focusing on the prevalence of suicidality based on different suicidality phenomena, starting from suicidal ideations to suicidal attempt. We can see that as one proceeds from suicidal ideation to suicidal attempt, the prevalence actually decreases, though not steadily. The same trend was also followed across men and women. It can be seen that the prevalence of all suicidal phenomena is observed high in women as compared to men. And the other most important finding that we can see is, as the level of suicidality increases, the difference in the prevalence that observed between men and women becomes less pronounced, indicating the need for gender-specific interventions to be included in the suicide prevention strategy. Sorry. Thank you, sir. Now, this is the other important table which talks about the risk of suicidality, higher risk of suicidality among the persons with major depressive disorders and alcohol use disorders, again indicating the need to strengthen the indicated interventions for these high risk vulnerable individuals. As you can note down, as you can go back and note that we have not put this table in the main manuscript, but we have included that as a supplementary appendix, just to say that suicide prevention strategies should not be reduced to the medical model, but has to be expanded to include the more inclusive social developmental model. And it has to be noted that the article has been published in the Fourth Psychiatry Journal, and we did not face any resistance for putting this table in the supplementary appendix. Now, extrapolating our findings, it has been found that at some point in previous months in a year, over 30 million Indians aged 18 years or more had thought about taking their own life, with 2.6 million had attempted suicides, a number higher than population of few countries in the world. Now, coming to the discussions, it is the comprehensive study so far to understand the epidemiology of suicidality in India. For a country such as India, which recently have launched National Suicide Prevention Strategy, the findings highlights the implicit need to address the multidimensional determinants of suicidality and death by suicides using a robust framework that should include gender-specific and life course approach, prioritize the suicidality in the ongoing health programs, particularly urban programs, and integrate with the social policies based on state-specific factors. The findings also reiterate the need to strengthen the assessment and management of mental disorders, particularly in primary care settings, followed by real-time data surveillance system for suicidality. Now, coming to the limitations of the survey have covered only 12 representative states of India, and we have not covered the age group less than 18 years of age. There is a lack of information on methods, immediate context, and communications of suicidality. The study, NMHS also did not assess stigma, help-seeking, and coping strategies specifically for suicidality. We also do not have data on emerging purposes like intimate partner violence and also among the vulnerable populations. Now, the commentary that was published along with the article also reiterated that the important actionable findings by this paper provides the leadership and strategic directions for establishing a national suicide prevention strategy in India. Without any reservations, I would say that this paper would serve as a catalyst for developing action plan and a robust framework for suicide prevention in India. Before conclusions, I would like to say that suicides are preventable. That is hope. It is everyone's responsibility. Thank you.
Thank you, sir, for this comprehensive presentation. Now I would request Gauri ma'am to share her thoughts on this. Over to you, ma'am.
Yeah, thank you, Dr. Sendil. That was very wonderfully presented, considering the lack of time and the amount of information that you had to present. I think very concisely and very crisply, you have brought out the importance and the differentiation between suicidality and suicide. We also have the stress on early intervention as one of the most important things, and an opportunity to address it at the national level. You have also highlighted the male-female differentials, the urban-rural differentials, and also the ratio of suicides to suicidality. So I think that gave a very nice picture as to which are the specific cohorts or maybe vulnerable population sets that we need to focus on. One very nice thing that you brought about is the socio-developmental model that needs to be focused on and not just the medical model. You have touched upon the state-wise action plans and the state-wide differentials. I would really have loved to see as to if we could come out with state-wise what are the latest or the topmost 3 factors for suicidality and attempt to suicide, so that based on that, state-level action plans can actually be compiled to enable to put in mechanisms at the national level. But overall, a very nice comprehensive presentation.
Thank you, ma'am.
Thank you, ma'am, for your insightful thoughts. Without further delay, let us move on to the last session on community-based model for suicide prevention. I would like to welcome Dr. Anish Sir, who is Associate Professor of Psychiatry Social Work, to give a speak on this topic. And then I would like to welcome Dr. Rajini Parthasarathy ma'am, who is a Deputy Director for Mental Health in Karnataka, to chair the session. First, I would like to I would like to call Dr. Rajini Parthasarathi ma'am to share her thoughts. Then let us move on to the presentation.
Yeah, our job is, good evening, everybody. Our job is, am I audible?
Yes, ma'am, you are audible.
Yeah, I think my job is made easy. We have heard about the demographics and the detailed presentation about the suicide prevention, the study, the protective factors. So what we need to really, concentrate on community-based models for suicide prevention, which is also very, very important. So we all know that the suicide prevention is not just the business of health department or any one department, and each and every person starting from the family, relatives, community, other departments like women and child department, education department, rural development, panchayat raj. So we have to rope in all the departments. So happy to share that, the Karnataka, we have district mental health program teams across the state in all the districts. And we have started many innovations in suicide prevention and then adolescent empowerment programs. One of the programs is the urban suicide prevention innovation that we are doing along with the National Health Mission, Government of India. Happy that Government of India is supporting us in the innovation. So we have, Anish is going to talk in detail about the innovation, what we have done. So maybe, I have an urgent meeting in the finance department. If at all, if I can stretch till Anish completes, I'll be talking after his presentation. So over to you, Anish.
Thank you very much, ma'am. Am I audible?
Yes, yes, yes.
You can see
Please.
my, yeah. Thank you so much for this opportunity to present you today. I'll be talking about community-based models for suicide prevention. We have tried a bit of this, and based on the National Suicide Prevention Strategy and the WHO Live Life Framework. As we all know, suicide is a major public health concern. As per National Crime Report Bureau 2021, we lost around 164,000 suicides in 2020. With the help of various mental health professionals, suicidologists, we have launched our National Suicide Prevention Strategy in November 2022, with an aim of reducing suicide mortality by 10% in 2030 through establishing effective surveillance mechanism for suicide, establishing suicide prevention services at psychiatric outpatient department through DMHP, integrating mental health well-being curriculum in all the educational institutions. These are the National Suicide Prevention Strategy. With that, we kind of started working around this, and we found a couple of pathways. There are various pathways to community-based services. We chose 5 different pathways to work with the National Suicide Prevention Strategy, which are developing surveillance systems, providing hospital-based services, developing and implementing mental well-being curriculums, integrating suicide prevention existing systems, and more importantly, advocacy as well. In suicide surveillance system, some of the examples which we also tried and we are piloting with the National Health Mission and various organizations. One is self-harm registries. We have Dr. Rajini was talking about the innovations from the Government of India provided financial support to us. We have actually initiated self-harm registry in 5 general hospitals in Bengaluru as a pilot, and we are actually now moving further with various districts and district hospitals and taluka hospitals. I'll come to that in bit detail later. And we also have suicide surveillance team. This is one of the innovations we thought each community after this COVID, we have each village and village and the panchayat has a panchayat level task force for COVID. We are training this village task force to act as a suicide surveillance team. The aim is to have a team for each village. So we are just piloting it now, and it's very effective. And another model is like suicide prevention action team within the organizations, schools and colleges. We have tried with the 2 industries and one organization and an institution. It's very the college is more of like a buddy system or a peer leadership to have a team of people who can actually act as a suicide prevention action team within the organization. And Dr. Senthil Reddy was talking about gatekeeper training. I think all of us, most of the mental health professionals are involved in gatekeeper training. We need to have more and more gatekeepers in providing brief interventions in the community. And another approach is like hospital-based services. In continuation to self-harm registry, we also provide brief interventions and safety planning, lethal mean counseling, and clinician initiated tele follow-ups and crisis helping. This is a kind of pilot work which we are doing it in 5 general hospitals in Bangalore. We call it as a vicious model. So over the last 10 months, we had around 2,521 patients with the history of 193 repeated suicide attempts. Among the group, I think Dr. Reddy was also talking about more, and Dr. Prabha was also talking about that. We have more and more young people among this group. I think if you look at, we have around close to 70% are less than 35 age group. And most of the common methods were poisoning and tablet overdosing. And with this intention, we also now launching a youth suicide prevention in the community level, where we are focusing more on youth and youth-related suicide prevention, and working with the various agencies to have more and more regulations on pesticides and pharmacies. And the more encouraging result in this is like it's a very, very cost-effective model, where we have a social worker and psychologists in each of our emergency departments. So over the last 10 months, if you look at out of this 2,521, we have reduced number of suicide attempts. Like we have around 7 reattempts and 2 completed suicides. And most importantly, 89% of the follow-up were retentions, because it's also encouraging. 80% of them are still connected with us, and we contact them very periodically, 6 times in after discharge. We contact them after a week after discharge, 2, 4, 8, 3 months, and 6 months, and these are the scheduled calls. But we also get they call us back to stay in touch. The understanding is that it's the patients who are attempted or self-harmed, they want to be in touch with us. They want to have some contact with the clinical team. And another approach what we have is mental well-being curriculum. Through our various PhD protocols, we are now developing various curriculums for some of the examples are mental health literacy curriculum for school teachers, literacy module for college students, and we kind of developed a suicide intervention module for professional social workers. And we also working with the journalism students and professionals. For journalism students, we have developed a curriculum for which the intention of integrating that with the regular ongoing classes. And we also have another PhD protocol which we have is training and module for primary care staff. The intention is like to have various models developed, and so that like any one of you are interested in kind of understanding more, we can actually have a discussion later sometime. And we also launch a certificate course for suicide prevention and mental health promotion with an intention of more of a capacity building in this area of suicidology. We also, over a period, we also realized working with the younger children, less than even 10, having mental health training or life skill education, integrating them in the schools and colleges with a lot of activity is also very, very useful. And we have initiated that, but in a very in almost some of the schools. But we will be doing that in a district. I'll come back to that in the little later. But we are going to have, this will be one of our major initiative to have school-based interventions. And another important thing, if you look at the national mental health strategy, was integrating suicide prevention in existing systems. So one of which very easy way of doing was in workplace suicide prevention. With an intention, we have approached to larger companies. So over the last 1 year, we have been working with them in integrating mental health in the existing their health system. Most of the organizations, most of the institutions and colleges has a health center or a counselor where we can actually integrate mental health in very easily. So in these two organizations, we are providing brief interventions, follow-up and referrals. Over last 10 months, we have noticed that we have provided more than 683 employees and provided around close to 65 people with self-harm attempts. And the very, very important result is like there is no reported reattempt after that. So that means like if you provide services, you can integrate services very, very, very cost effectively in the ongoing existing system and prevent suicide. Another approach is like training helpline counselors. Basically, if you look at, we have 104 various helplines, training these helpline counselors for facilitating suicide or crisis interventions for persons with suicidality. And if you look at, when Dr. Reddy also talked about developing capacity or capacity building for key stakeholders, various levels. I think if you look at the training happens in NIMHANS with various key stakeholders, ranging from school teachers to ASHA workers, range of people, Army, Air Force, various stakeholders. I think it will be the number will be very, very huge. And we also provide how to provide psychological first aid and advanced training for providing suicide brief interventions, especially for mental health professionals, psychologists, social workers, medical professionals, and nurses in providing brief interventions. And these are some of the glimpses of our training programs. It's more of an activity-based or more of a participatory model which we follow. And if you look at the range of people who have been training. And we also take a longitudinal approach for suicide prevention. A couple of projects which I want to mention is like based on our experience with various stakeholders, we thought it's better to have take an entire district and provide comprehensive community-based approach. We call it as Suraksha. And based on our experience with the various stakeholders, from the learnings from WHO's Live Life Framework and National Suicide Prevention Strategy, we kind of developed 6 work packages to provide a comprehensive suicide prevention strategy. One is that community-based suicide prevention suicide surveillance team, which I already mentioned, which the aim is to have each village having a team of appropriate mental health services. And we also, if you look at some of the work, WHO also recommends centralized special storage, where reducing the access to means. So we are also planning to have to initiate this work, but we are planning to have each village will have a centralized special storage. And we already started this brief intervention for self-harm and suicidality. The aim is to have all the medical places, like it could be PHC, CHC, or Taluka hospital or district hospital, having a kind of registry as well as providing brief intervention, and centrally provide telephonic or tele-based follow-ups, contact-based follow-ups for at least 6 months to reduce suicidality, and they can actually reach out to us. And another program I mentioned already, that is a school-based programs for schools, school children and colleges and teachers as well. So another work which we're also is training media professionals. Along with training them, we want to engage with them in each steps, where, for example, we are now working with some of the newspapers that whenever they publish some of the news on suicide, we contact them and kind of discuss with them about how they can actually improvise their reporting strategies. And we also kind of develop different IEC materials, and for various range of, it could be for general public or schools, colleges, hospitals, and we also involved in social media interventions. These are some of the activities we can actually have comprehensively do it for a community. This was launched recently in one of the places closer to Bengaluru. It's Ramnagar. And we are kind of now developing, doing a lot of formative work to implement this work. Another work was occupational well-being approaches to suicide prevention. We also realized, I think it's easy to work with organizations and where they have an existing health system or existing system. But I think we thought like we need to have a very broader approach. It's not suicide prevention, but I think we thought like we'll approach a little more differently, like occupational well-being approach, where we will have a gatekeepers equipped to facilitate suicide prevention and provide first aid in the occupation, the workplace. And we also thought we'll have mental health literacy training and life skill educations. And we also thought like young people joining industries and organizations, we need to have financial literacy. And for women and women employees, we thought should have a reproductive health training and family education. Substance abuse is very common, so we thought like we'll have a substance abuse management as well as. And we also kind of advocacy work with the higher management to have recreation and leisure time. In term, it will reduce stress and work-related issues and improve work-life balance, improved occupational well-being, increased productivity. In turn, this will reduce suicidality. We have been working with two major organizations, which is very effectively and functioning, and we have completed the formative work, and we have developed the modules. If anyone wants to work with us, the models are ready to implement across. And as I mentioned, this involves various activities, and it's more of a participatory kind of activities and modules. And as a mental health professional, it's also very, very important for us involved in advocacy work. Primarily, now we have a national suicide prevention strategy. One is to implement in all states and districts. And we also, as a regional challenge or responsibility for us to encourage the regional or other countries. Dr. Reddy was talking about, we have around 40 odd countries having national suicide prevention strategy, but encouraging others and mentor other countries to develop and implement a suicide prevention strategy, and involve in developing and implementing suicide prevention strategies, colleges, institutions, various organizations, and work with the different governments or various state and national governments to kind of, especially in India, we need to work with each government, state government, to implement suicide prevention strategy. We already have, I think we have all plus 1 year now. So to conclude, suicide is a very major concern, and if you look at the results, what we know so far, my understanding is like we know only tip of the iceberg. There is the magnitude of the problem is quite huge, and which requires to address this. We requires very comprehensive prevention approaches. Strengthening existing programs can be a cost-effective approach to suicide prevention, and it's very cost-effective. If you look at most of our models or the existing model across, it's very cost-effective. It's not very, and we try to integrate the suicide prevention or mental health within the existing system. And implementation of suicide prevention in community requires multi-level intervention and huge collaboration with various stakeholders, various departments, and organizations. This I'll conclude my speech, and I thank to all the collaborators, and it's a very, very it's a multi-sectorial and various organizations involved, funding agencies, various people, and the government. Thank you all.
Thank you, Anish. I think it was a wonderful presentation. I wouldn't repeat everything. What is very important is community-based models are very, very important, and and suicide is preventable. And the highlights were in our study, if you see, and the whole presentation, the community-based intervention, how available resources are being utilized. Because any project, program, innovation, it works when it is in the project mode. And what we do, we should be very careful that it should be a sustainable and replicable model. Here, it will be very, very sustainable because the available resources like panchayat task forces are being trained, sensitized, and then hospital staff who are available are utilized. Only one social worker, psychologist, we have recruited additionally, and linkage with the available DMHP staff, district hospital, medical college staff. And then even in the school-based programs, all are available resources. So you also saw the workplace interventions, media alliance, and so on. So thanks, Anish, and thanks to the organizers for this opportunity. Thank you all.
Thank you, ma'am.
Thank you, ma'am, for your informative thoughts. And also thank you, sir, for this informative presentation. Now we shall move on to the Q&A session. I would request our speakers and discussants to answer the questions that has been raised. Thank you.
Thank you, Dr. Navya. I think I'll just take over from here. And looking at it, I think Dr. Anish has already answered the first question in terms of saying, do you have a gatekeeper's course for family carers, a crash course from Mr. Venkatesh Prasad Iyer? Dr. Anish, would you like to respond to that, or Dr. Senthil Reddy?
Yes, sir. Yes, sir. Thank you so much, sir. It's a very, very important question. We don't have a family-specific training program, but we are planning to launch a program for families who lost. So it will be a kind of platform where people can actually, family who lost can actually come and have interactions. It's not a training program, more of a sharing or interactive methods.
Okay, okay. Possibly if you could share your
yeah, sure, sir.
Share your email ID onto the chat.
Sure, sure.
In case they want to write to you, and then they can get in touch with you.
Sure, sir.
Yeah. Second is, I think Dr. Abdul Majid from J&K talks about educating students, parents, employers, faith healers, religious leaders, preachers, teachers regarding etiopathogenesis of self-harming behaviors, and need for early intervention could result in addressing the issues at grassroots level rather than look at Western models. Yes, Dr. Majid, I think we agree with you on that.
Yes, sir. Involving all the stakeholders very, very important when we do a community-based or any kind of interventions. Very important point. Thank you so much.
I think the other remark from Dr. Abdul Majid is in terms of the media needs to be sensitized as to how and when to report. Dr. Senthil Reddy could answer this question. I think there was a PhD work from NIMHANS Psychiatry Department. Is that right, Dr. Senthil?
I don't recall it. I'm so sorry.
Okay.
It might be another department probably, but I can assure you that essentially, I think obviously Anish is doing a little bit of work there right now. Yeah. But I completely agree with Dr. Margaret in the fact that what are the approaches to adopt? It's a two-pronged approach. We actually have the sort of the Press Council of India come in. So obviously now the issue of media has evolved dramatically. So one is we're talking about the print media, and are we talking about the audio-visual media, which are the traditional formats of media. And in these two constructs, the Press Council is the sort of agency that has actually prepared guidelines. However, and these are just, sort of guidelines, but they are not mandatory. They don't have any legal, sort of, oversight or, control. However, these guidelines, similar guidelines have been sort of developed and prepared in different parts of the world, which actually have legal implications. So by law, a lot of other countries, there are certain aspects relating to the events that cannot be shared and disclosed, like the methods, the particular site, so anything that could potentially identify the person who's lost their life to suicide. So the approaches that we have undertaken at NIMHANS as a large group of people working in this area is that we have actually been interacting with groups of media personnel and helping them understand how it's important not just to focus on where they place the article. So for example, currently, apart from on the front page, which is obviously an absolute no-no, quickly, to cut a long story short, it's currently still placed in the crime pages page, which is actually with other crimes. So it sort of indirectly increases the stigma associated with suicide. The second thing is to focus on the positive, components of issues that may be, helpful for other individuals who could be struggling with these issues in the community. Rather, so the incident can be not minimized, but minimally communicated. And then subsequently, there's a strong and heavy focus on what are the prevention strategy, what are the warning signs, where are the places to seek help, etc., and put in helplines. So those are very, very important. The other is obviously including this into the curriculum in the media courses.
I'm just, I think we need to have a bigger session on media and reporting of suicides. But point noted, yes, I think the first thing is move it away from the crime beat pages. I think that's at least a minimum thing which they could start off without compromising on any other issues which they're talking about. Dr. Senthil, there is another question here. What is the percentage of suicides attributed to mental disorders in India? This seems a bit looking at, we talk about depression and suicide. Would you like to answer this? Yeah, you're muted.
I said I wasn't sure whether this question was, I didn't know the question. I wasn't sure it was from the NMHS query or with Dr. Sendil, who's my namesake, or
okay.
Probably me.
Sure. We can ask Dr. Senthil Amudan. Dr. Senthil, did you notice, has this been highlighted in the NMHS 1, Dr. Senthil?
Yeah, thank you, sir. So in fact, this is actually $1 million questions that we know that what proportion of mental disorders people are at risk for are going for completed suicides. But when it comes to suicides, what proportion of the people are contributing to mental disorders actually a question. In fact, this is the argument that actually places to show that though people at mental disorders are at high risk for suicides, it does not mean that suicide is the highest contributor for suicides in India. So that actually brings out the other social factors and other things. But actually, we don't have a data to say on that. But the people who go for suicide as a social phenomenon will agree that definitely mental disorders are not going to be a significant contributor compared to the social factors for the suicide.
Yeah, I think we were supposed to have Professor David Sheehan talking about these several constructs, but unfortunately he's got caught in a natural calamity situation there, and then he's volunteering. So that is why he's asked us, he sent us his apologies. We would try to reschedule his session sometime later. But again, as Dr. Senthil Amudan said, yeah, this is a tough question to answer in very specific terms. I think that there are various paradigms which we need to look at. Okay, I think the next question is 33% of suicides are due to family issues. What specific family level interventions incorporated in National Strategy for Suicide Prevention? What are the specific family level? Any qualitative inquiry into family issues resulting in suicides? I think both Dr. Senthil Reddy and Anish. Anish, any insights from your project activities?
We have initiated some work, sir, but not family. One of our PhD work is on that families of people who are actually attempted. So it's like it's not the questions they asked is like what are the reasons for this? But I think we have not explored so much onto that. I think for our formative work we might be able to provide some, but I think at the moment I won't be able to provide that information. So.
Okay.
Just if I can add in briefly, this is because specific pertaining to national suicide prevention strategy. What's been advocated is about women empowerment through various existing schemes, through protection through domestic violence, because these are pertaining predominantly these aspects of family issues, etc., and family level issues are, I think there's a large proportion that relates to women. And so it's about the National Suicide Prevention Strategy, highlights the need for the, women development and empowerment, the department or the ministry to actually undertake that responsibility and ensure that they can provide the requisite supports. A lot of them are already in place, but creating awareness of the availability of these supports. and also undertake exercises in negotiating through family dispute, etc., to facilitate that, rather than the health ministry.
Yeah. I think non-health or health-related ministries need to be a bit more sensitive and active towards that. I think this is a good point for convergence. There's another question which says there used to be an initiative called Supremac. I haven't.
It's Supremess. It's the Supremess study.
Yes.
Yeah, the Supremess study was, between Brazil, the BRICS countries, I think,
Yes.
and it was undertaken as a part of the WHO initiative. It was many years ago. It showed effectiveness of brief contact and reduction in suicide risk or suicide reattempts amongst individuals following a brief message-based contact. So very, very cost-effective in the interventions. Dr. Lakshmi Vijayakumar was one of the investigators of that study. She was the one from India. And so they demonstrated a good, but that was just a preliminary findings. Unfortunately, subsequently, there have been no publications and no further literature that's emerged from that Supremess data, or there's no source that I've come across.
Okay. Now, I think these next two questions are to Dr. Anish. May we know how we can access these curricula? I think, yes, I'm also keen to have a copy of it. Is there a web page, or can we write to you and get it? Is there a separate module for school-based intervention?
Yes, sir. So we are developing it, sir. These are all PhD protocols, and it will be published soon, sir. I think it's not to finalize, and we can share it in case, like, if someone is interested. Yeah.
Okay. I think Dr. Senthil Amudan has shared his presentation. I think, Dr. Rajani said, why is there no eye on men's mental health as in 2021? Male to female ratio 72:25. I think Dr. Abhishek Mohanty wants to also look at men's mental health and link it up to suicide. Yes. So what about designing policies and laws for men? Yes, definitely needed. Anita Rego, one missed out department is women and child development, present and disabled. I think Anish was mentioning, and even Dr. Rajani mentioned about involving several departments. I think
all the departments are involved in the community-based. But I didn't have the time to present what department very specifically, but I think it's a very comprehensive kind of thing. All the departments are involved from the state.
Yeah. I think that's what I think. Anita, we agree with you. Layering suicide prevention is easier on these programs existing, because that's also a platform which is available. Dr. Senthil Amudan answers, NMH's finding supports the argument that we should have gender-sensitive approaches for suicide prevention to accommodate the gender paradox in suicide and suicidality. Yes, Dr. Senthil. Evidence-based school interventions in India. I think, again, back to you, Anish. I think, as you said, please share with us the manual as early as possible.
Yes, sir.
So that it could be available. We'll be happy to share it as part of our NMHS web page, apart from wherever your primary source of sharing would be.
Sure, sir.
Yeah. Again, missed to join. Okay. Please give examples of school age and college based interventions in India. I think you can write to Dr. Indu separately and then take it up from there. Shweta asks, who would be the authority to take up means restriction? For example, pesticide poisonings. Would the health ministry interact with other ministries to take regulatory decision? Access to type of means of suicide determines fatality. Even a low intention self-harm can result in death if lethal means of suicide are used. Yes, I think Dr. Senthil Reddy mentioned about it in terms of looking at the policy initiatives which have been taken. Dr. Senthil, quickly, could you respond to that?
Yeah.
I see 11 other messages.
One Dr. Anish alluded to already in terms of how to develop, a sort of a repository or a place to store all the pesticides in a village at a village level itself. That has been demonstrated objectively through a study again undertaken by Dr. Lakshmi Vijayakumar in Tamil Nadu, where actually they compared two different villages. They set up the system in one, and the suicide rates in the subsequent 12 months actually came down as a consequence of pesticide poisoning. The other is obviously like the Sri Lankan model to switch to more of non-toxic pesticides. So actually that will entail obviously government level policy decision making, and to gradually switch over from non-toxic, non-poisonous pests, which are pesticides nonetheless, to not really affect and influence agriculture. So again, it's the Ministry of Agriculture, etc., as well as the policy government, policy initiatives. I would look to means restrict there. Although hanging still remains the number one cause.
Yeah. I think, thank you. I think that's a larger policy decision also, but we have sufficient insights from India as to what we could do. That's the bottom line there. Yeah, Dr. Satyajit Haldar says decriminalizing suicide attempt and counseling as a cry for help should not be ignored. Not, sir, it's not just 2-bit, but that's the main strategy which we need to be looking at. Anita again puts this question of what to do for people who lose jobs. Yes, Dr. Vaishali Raje, yes, we agree with you. Marriage counseling may bring about families' mental health. Yeah, marital counseling, marriage counseling, I think that's something which needs to get formalized. I think policy for pesticides is the need of the hour. How do we promote? I think just now Dr. Senthil Reddy has answered that. Yeah, I think Shika has asked this question, Dr. Senthil Amudan. I just missed it. That during data collection, people threw stones at the team. Did we miss out something? Did I miss out something, Dr.
No,
Senthil Amudan?
Yeah. So actually, we have I've given a clue that getting the data from the community from suicidality is not that easy one, and I've told that we have experienced that few villages we have faced this problem. I think you will be the better person to tell about what happened in other states. And one the strategies that we applied is in case of mini version 6, the mini was the suicidality was the second module. So we have shifted that to the later module so that we get the better response, and we also have involved the community leaders and sensitize the community so that we get better positive response from with related to suicidality. Though getting suicidality from the children is always a challenge we faced.
Yeah. I think that was one major challenge what we faced in the community, because suddenly they started, what are you coming here and asking us about death and suicides? You are initiating things rather than solving. Yes. I think as community medicine people, I think we develop strategies, and then, as Dr. Senthil said, one, push this module to the last so that it doesn't become sticky, or it doesn't trouble us for collecting data. I think the last question, I will take the privilege to answer it. How far have we come in terms of media reporting? I think Kerala has done substantial work, or at least documented work with respect to media reporting of suicides. I remember Dr. Mohan Isaac mentioning a lot about it. But there is always an issue with respect to these OTTs and social media. Seems to be a free for all. Even in the regular media, there is just to share one of our earlier experiences. We did a session with all the journalists or the reporters. But we came to know later that more than the journalists, despite their copy editing being fair enough to what is expected as an ideal, it is the news desk or the editor's desk which sort of twists the tale so that it becomes more quote unquote sensational. Well, it is 2 steps forward and 1 step backward, or it goes forward and backward. But that is where we need to look at a larger societal awareness, which would help us. Well, I think that's the end of the questions. Thank you very much, all of you. I think we'll continue with the dialogue. We would like to look at next edition of the dialogue sometime during the month of November. We hope to request Professor Sheehan again, if in case he is free, to join us for a discussion. And also we want to look at tribal health as one specific focus, because that's another area which we have not ventured more. So with this, I take this opportunity to thank Dr. Senthil Reddy, Dr. Senthil Amudan, and then Dr. Anish, And the chairpersons for these 3 sessions, Dr. Prabha Chandra, Dr. Gauri Sengupta, and Dr. Rajni. We are indebted for all your thoughts and insights. On your behalf, I think this entire video would be made available on our NMHS website, so that anyone who has missed it can have a relook at it anytime they want. And I would also like to thank Dr. Navya and Dr. Sonali for anchoring the show, and Dr. Shubhi Nema for coordinating the entire set of activities, and the background boys, Robin, Sanu, and Shireen. All of you, thank you. Hats off to you for making this possible. Thank you, one and all. We take leave now. Have a happy weekend.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Girish. Thank you. Appreciate it.
Thank you.
And congratulations to the entire team. Thank you.
Thank you. Thank you.